Okay. So ventricular prevalve rupture, it is again a rare complication. It is the mechanism is same as an acute MI. So we'll again start with our case study. This was our patient who presented with a 69 years male. He had an anterolateral MI. It was a late presentation. Patient was taken to the cath lab. To PCI to LAD was done, and then they were planning to do a cath to the circumflex. After PCI to LAD, he became hypotensive. He was resuscitated. IEBP was put in, and he was started on inotropic and vasopressor support. LV angiogram was done, which showed an LV rupture. Then we'll see the image later on. And echo was done, which showed a cardiac tamponade. We'll see in the next slide. And they tried to, pericardiocentesis was trying to, in the cath lab to try to stabilize the patient. Cardiac surgeon was immediately called. So what we did, we shifted the patient to the OR for the salvage repair, and linear closure of the LV prevalve rupture was done, and patient recovered well. So this is how this patient is present. Very, very prompt action need to be done. So what we did, this echo was done in the cath lab, because when the patient crashed, and you can see there is a fluid collection in the pericardium. We don't know what it is, but usually it is a blood, and the RV is collapsed. So in acute settings, you don't need a large pericardial effusion. In acute settings, I think even 100, 150 ml is enough to cause a cardiac tamponade. But in chronic settings, you may see 300, 500, even a 1 liter of fluid without any cardiac tamponade. But in acute settings, the pericardium is not stretchable, so they usually go in tamponade or shock state very early. So then they try to put an angiogram, LV angiogram. I think there was some leak and collecting in this area. So surgeon was immediately called, and we shifted the patient to the OR, and then we put a linear closure of this defect, and then patient was shifted to the CVICU in stable condition. So this is how this patient is present. So left ventricular prevalve rupture is a life-threatening mechanical complication of acute myocardial infarction. As we saw in our case, if you do not promptly act, the patient may die immediately. With current literature, as we presented in the VSR, is the same publication, where around 9 million patients were there. It showed only 0.01% of acute MI cases, whether STEMI or non-STEMI, they have the same incidence. But in the autopsy series, there is a high percentage, usually 10 to 30% of such patients have a left ventricular prevalve rupture because of the sudden cardiac death. I think we'll bypass this slide. This is just okay. Let us go historical background. Usually the first case of left ventricular prevalve rupture after myocardial infarction was in 1647. Obviously, this will be an autopsy case. 11 postmortem case of myocardial rupture, and ultimately himself who died is Morgagni. He himself had a myocardial rupture. Eventually, he diagnosed in 11 patients, but himself unfortunately died of this one. The first surgical successful repair of the right ventricle was done in 1971. Then the first successful repair of the post-infarction left ventricular prevalve rupture with direct suture was in 70. And then the ruptured myocardium, the Dacron patch, was done in 1973. And nowadays, sutureless epicardial patch technique is popularizing, particularly in the oozing type of the prevalve ruptures. Just put a patch and come out. I will not go through this paper. I think we went this paper in detail in first presentation. So we'll directly go to the etiology of prevalve rupture. We are discussing here acute myocardial infarction, but remember there are other causes of prevalve rupture. It could be trauma, blunt trauma, or penetrating trauma, cardiac surgery such as post-MVR or transapical AVR. They can have the perforation, even a tumors or an infection. They can have just an idea. There are other causes other than the acute MI. I think
Dr. Shabir, sorry for interruption. I think you bypassed the classification.
About prevalve rupture?
Yes.
We will come.
You said,
yeah, I will.
Okay.
I will give in detail. I will do in detail. Okay, so because yes, Dr. Hussain, that your management depends on the classification. Now we classify them and treat them according to the type of the pre-valve rupture, which will be coming in next few slides. I think pathophysiology is same as we saw the VSR. You have an MI, transmural infarction, expansion, thinning of infarction. Ultimately, the pre-wall exceeds the force of generation by the LV ventricle during systole and it ruptures. The pathophysiology of VSR and this is same. Now your pathophysiology. So acute ventricular pre-valve rupture, it could be blowout type, okay? Generally, it results in acute pericardial tamponade. It is a just blow. It is acute tamponade, as in our case, which we present case our case report, followed by shock. There is electromechanical dissociation and death within minutes. So these are the blowout. They may just die in front of you within minutes. Subacute, which we call it oozing type, what initially involve a smaller ventricular free wall tear, which becomes partially sealed by a clot and pericardial adhesions. So they have, you have a time here to plan your surgery. And third one is a chronic left ventricular free wall rupture, which is actually a pseudoaneurysm. Okay, so there are three. So this is a classification by Becker and von Modgen. You may see in the textbooks this classification. Type 1 is, as we say, blowout type. Type 2 is an oozing type, where it is a subacute type. And the third one is a pseudoaneurysm. Is this clear now, Dr. Hussain?
Yes.
Okay. So we have type 1, type 2, type 3. So type 1 is an blowout, type 2 is an oozing type, and type 3 is a pseudoaneurysm. So this is Becker and Montgam. But so your management depends on blowout, usually need a suture technique. The type 2 oozing type are usually now preferred, but the sutureless technique. And the type 3 is a pseudoaneurysm, which we'll discuss. We will show a couple of cases of pseudoaneurysm as well. They are usually chronic cases, pseudoaneurysm. Okay. So how do they present? Again, they could be severe hemodynamic instability and shock state. So if you have a blowout type, you have a shock state and an impending death. So they have ventricular fibrillation, electromechanical dissociation, cardiac arrest, as in our case. The chronic left ventricular free rupture or a pseudoaneurysm, they are usually stable. They may present with heart failure. They may present with other, sometimes with a marginal hemodynamic instability. So diagnosis. Again, the echocardiography is very important. The presence of reduced myocardial wall thickness, you can observe. You can observe the pericardial collection, hemopericardium, or clots, or cardiac tamponade. Very, very important to, but you cannot certainly whether there is perforation or not. You can, pericardial effusion and hemo does not mean it is a perforation. Pseudoaneurysm is a contained rupture with pericardial adhesions. Pericardiocentesis, it can help, you can suck the blood. And contrast ventriculography, if the patient is going for coronary angiogram in stable patients. But in our patient, as we discussed the case, he was already on table. Post PCI, he crashed, so they put a ventriculography. Otherwise, you will not see this type of, they don't do a ventriculography. And CT or MRI in stable condition, like pseudoaneurysms. In our case, you will see this, one of our cases, we did a CT scan, and 2 of our cases, we did a CT scan, not MRI, and which confirmed the pseudoaneurysm. However, definitive diagnosis is made only by the surgery, particularly who are in acute free wall rupture. So preoperative management, you have a diagnosis or you have a high suspicion of post-acute MI left ventricular free wall rupture. How you will diagnose or how you suspect, because you have pericardial effusion, patient tachycardia, ongoing chest pain, has an echocardiogram with signs of infarction, epicardial clots or hematoma, or pericardial effusion. Patient is not doing well. So you have a suspicious. So patient is clinical status. If the hemodynamically is stable, then inotropic support, and eventually you have a time to take him to the OR. If the patient in cardiogenic shock, as was our case, you have to start some inotropic support, intravenous fluids, IABP, Impella, pericardiocentesis, try to suck out and stabilize the patient, and eventually take to the cardiac surgery immediately. If the patient has a cardiac arrest, now you have to do a CPR. pericardial drainage, it could be percutaneous, and put the patient on mechanical circulatory support, particularly these are cardiac arrest. If you think that you don't know their outcome, so better put them on an ECMO. And then if they recover, show the state of recovery, then eventually you may take them to the OR. What does the guidelines say? European Society of Cardiology and American Heart Association guidelines for the management with STEMI advocate the use of mechanical circulatory support such as IABP or ECMO in patients with post-acute MI mechanical complications and hemodynamic compromise in order to achieve temporary circuit stabilization on the way to surgery. What I suggest is, so most of the patients, if you'll see the article, more than 50% have an IABP. And nowadays trend is the patient is not doing well and has a multi-organ failure, better put them on ECMO. If they show signs of recovery, then take them to the OR. What techniques we use? We use a surgical techniques. We use surgical techniques like linear closure as we did in our patients. Another, we remove the infarction part and then closure again with a linear closure, or a patch covering is done with the stitches. Or nowadays, if you have an oozing type, you can just sutureless technique is enough most of the time. What we use surgical material, different materials have been used for patch closure. Most commonly, we apply a Teflon patch or a Dacron patch or a pericardial patch, which could be autologous or it could be xenograft. Collagen sponges, which I usually use a Tacosil, is a very good, just put it on the oozing type or there's a hematoma. Just put it and leave it alone. Or sometimes we use a biological glues also are using, or combination of these, we surgeon and the OR tries combination of these things. Even a cyanoacrylate monomers, which I have no idea, but it has been reported, but I never used them. So this is how we do a linear closure. We put a Teflon felt here, Teflon felt here, and then try to suture them. And this is a patch defect. If you have a large perforation, blowout perforation, you may have to put a patch, put a palliative sutures around it. Then on top of it, we put again a Tacosil or something. And there is another patch covering technique. So you have to modify your technique as per the need of the patient, whether he is a blowout or he is an oozing type of the defect. So you use your technique as per the patient demands. So sutureless repair, the patch is applied to a wide cover, the ventricular wall rupture and the adjacent infarcted tissue, particularly using oozing type of the repairs. And biological glues are effective only in absence of active bleeding. So glues should be preferably to be used if the tear is sealed, or you don't see any bleeding, it is sealed well, and the lesion is of oozing type. Just put this kind of patch. I think probably this is a Tacosil here. This is how our case, what we discussed here. This was a perforation. He was actively bleeding from here. So what we have to close it was, and this one we put a palliative suture, it's a linear closure, and that was it. But in this case, we put a cardiopulmonary bypass, I think. I think another thing I will tell you, these patients, I think I forgot to make a slide. Do the patients need a cardiopulmonary bypass always? No. So suppose you have a patient who has an oozing type and you take him to the OR, just if you open the sternum, see if there is blood, and suck out, wait for some time, there is no collection, there is just hematoma around, just put a patch over it, Tacosil patch, and leave it. So you don't have to go even on bypass. Some patients who are, as we said, blowout, who are unstable, then you need to go on bypass. And on bypass, you can, and if it is not an active bleeding, you can stitch on a beating heart. If it is tearing, and then you decide to go on cross clamp. So these patients can be done without cardiopulmonary bypass, with cardiopulmonary bypass, without cross clamp, and with cardiopulmonary bypass on cross clamp time. So depending on the case scenario, you can choose your surgical plan. So early mortality rates of surgical left aortic repair has been reported in 1734, even higher. So depends on the study and the type of the patient. Mortality varies. But if you're on oozing time, surgical outcome is great. If you have a shock state and blowout time, they usually die, most of them. An increase in percutaneous mechanical circulatory support cases suggesting that complicated left ventricular prevalve rupture cases might benefit from this approach. So there has been some reports where they use a percutaneous, they use the mechanical circulatory support to stabilize the patient. This study was recently reported, I think in 2018, a single center experience. What they did a 35 patients underwent prevalve rupture over a period of 16 years, and in hospital survey was 65, and it means around 35% had died, but in 13% survival patient present with cardiac arrest, and overall 5-year survival was 5% and 10%, and 5-year survival was like 53% and 10-year survival 49%. Anterior wall perforation was 17%, lateral wall is commonest one, and inferior wall is 28%, and posterior wall is around 11%. I think sutureless. Okay, this paper, I think it is not clear. Let me read it out for you. Sutureless repair of post-infant left ventricular prevalve rupture. It was done in 42 patients, again over a period of 15. Interestingly, oozing type was most of the patients out of 42, 33 were oozing type. So 94% were of oozing type, and blow up was observed only in 6%, 2 patients, and they just put a patch. They didn't stitch it. So in hospital mortality was 17%, and 6 patients died. Rupture after sutureless repair occurred in 17% of the patients, and both of the blow-up type, they had a recurrence, so they have to take him back to the OR and fix it. So when you have a blow-up type, when you have a oozing type, most of the time you can just put a patch and it is enough for them. This is another study in 2019, a recent study where you can see 42 patients they operated over. I think this is the same case as we did. I think same page. This is a clear slide. So Tacocil was used here, and 17% mortality, and 94% were an oozing type, and 2 patients had a prevalve rupture, blow type, and both of them had a recurrence of the rupture. So you can have an excellent result with a sutureless technique if the patient has an oozing type. This is one of the studies our center, King Fahd Medical City, is participating. I'm one of the authors in this. This is early outcome after surgical treatment of post-infarction left ventricular prevalve rupture. It is an international multi-center study, mostly from the European countries. We are 15 centers in participating in this. We have written a manuscript and has been submitted for the publication. I will just present. It is not yet in the. Maybe hopefully really soon you will see this publication. This is the largest series of prevalve rupture. 140 patients, we saw 140 patients of left ventricular prevalve rupture. 15 centers are participating in it. This data was collected from 2001 to 2018. As I said, our center is one of the participating center. Mean age is 69. Oozing type was reporting 56%. Blow type in 43%. Suture repair was used in the 61% of the patients. The overall operative mortality in our series is 36%. Preoperative left injection fraction, cardiac arrest, and ECMO support were independent predictors of early mortality. No significant difference was observed with respect to surgical technique, whether you do a sutured or sutureless technique. And the use of mechanical circulatory support was not associated with lower mortality in these cases. Myocardial rupture after cardiac surgery occurred in 10 patients, so 7.1%. No benefit affected. Addition of the cardiac cabbage did not show any beneficial effect, but there are some case series and some studies where they said that the associated, if you do a simultaneous cabbage, they have the better outcome. So any question is regarding the acute prevalve rupture?
Thank you, boss.
Okay. Yes. Any questions about acute? You know, it is like acute, not in a chronic, because I will show you some slides about the chronic free wall rupture. Basically, it is a pseudoaneurysm. We'll show a couple of cases about them, and then we will review a clinical scenario.
Do you usually do revascularization in this patient, or same for VSD? It's depend on the patient, and most patients they will not need revascularization.
Hussein, to be honest, you know, our mechanical complication, I think we have 14 or 16 cases. I don't remember. Most of them are 12 or around VSR. I think 2 or 3 are acute left, free wall rupture. So it is difficult. This patient was just crashing, so we do not do anything. So another patient, I don't remember we did a cabbage or not, but most of the cases were in acute setting. So just fix the perforation and get out. Because our cases are usually in a shock state, so I think better to to come quickly out of the OR.
Thank you.
Any other question? Yes, Dr. Haitham, you have any question?
No, thank you.
So should we go now? Why don't we go to the, I will show you a couple of cases of pseudoaneurysm. Is that okay?
Okay.
Assalamu alaikum. This is Uthman from Babtain. Doctor, thank you for this presentation. We have just a case a few days ago. I'm not sure it is was the right decision or no, just because it was the same as Hussein saying. This patient, he presented with MI, then they did a stent to the RCA. After that, the patient have developed tamponade. They found there is some tear in the RCA. They tried to fix it, stabilized. Then patient again bled. We took him as a salvage. There was 2 ruptures and the two perforation in the RCA, and the pigtail they inserted for drainage was through and through the LV. So we closed the LV with a linear closure, and also he tried to fix the RCA and did graft for the LAD, and he grafted also the RCA. Patient till now it's about 5 days now in ECMO. There is some improvement, but I'm not sure this is the right way of doing it or no. I don't know.
What is, no, you put an ECMO because of the RV failure, right?
We did an ECMO because there's the contractility is about less than 10%.
LV.
Yes.
What about the circumflex? His circumflex is normal?
Yes. He was in a case for just they did stenting for him, and they just took him for a salvage.
What?
It was acute STEMI or
acute? Yeah, acute inferior.
His ejection fraction was, how much was before you took him to they took him for the PCI?
Ejection fraction was low also. It was maximum 25.
Okay. Basically, you know, these patients' outcome is not a perforation, of course. You know, it is now his myopathy will describe, his coronary artery disease will describe his outcome. So yeah, as you said, I didn't show you, I had one case, maybe I think 1 year back, the patient, they took into the cath lab, and there was some mishap happened. Similarly, they put a percutaneous percardiocentesis, and it was in the LV. Okay, as you said, it was near the apex in the LV, and they put then another catheter, and they were sucking blood from the LV and trying to, that stabilize the patient. And when we shift him from the cath lab, I opened, and cardiologist was telling me that I'm sucking, patient is stabilizing because of this, I'm sucking it. When I opened him, I told him, hold on, there were 2 catheters. And I showed him that you are sucking from the LV, not from the pericardial central catheter.
Yes.
Very awkward. You remember Haitham?
Yes.
Dr. Hassan, yeah, I need it. So,
Yeah,
I mean, things happen, yes.
Me and Khalid actually were in that case.
Okay, yes. So, yes, we had a similar case scenario. I think these patients are crashed, but he had an uninterrupted recovery. But Alhamdulillah, he did very well. I think in your problem is, the patient has an advanced cardiomyopathy, ischemic cardiomyopathy. He had a 25%. Now you fix it you did a good job. I mean, you open him immediately, you try to fix it. But, patient has an insult. So he's on ECMO. This is the right thing to do. I mean, you have no other option here. You cannot leave him. Maybe his myocardium will gradually come out of this insult. I don't know how is his RV. If it was a distal RC, maybe RV will start coming out. The problem here is LV. Is he on IABP?
Yes, he is on IABP also.
Yeah. Very important in case of you need to put an IABP. There is no other way. So I think hopefully, I think you guys did a great job, and just support him in an IABP, and he may stabilize if his RV will recover, his LV will recover eventually, and this is what has to be done. No, I think to me he has been managed very nicely. Great job.
Thank you. Inshallah.
Right. This is actually what he presents is different. It is a complication of the PCI perforation, and the mortality for it is really high. The perforation of the coronary artery, and we don't know about the left main, man, if it is dissected or not, and that will also tell you about the possible prognosis with this patient, the wiring and all that, and they carry high prognosis. If this is similar, Dr. Shabir, to the one M&M I present, the one with the perforation of...
that patient was a left main dissection, and that is a different scenario. Here, it is an RCA issue. There is no untoward in this case. Uthman, sorry, what is your name? So it is in the RCA was a problem, not the left main. We have another patient who had an RCA, who was a left main dissection, and then the patient had a difficulty. He died. Sorry, I have to take one call, please.
Okay.